Thank you, Mr. Chairman. Good afternoon, ladies and gentlemen. First, I would like to extend my sincere thanks to Dr. Greg Patakos and the organizers for this kind invitation. I'm honored to be part of this important meeting. It's always great to be in this beautiful country. It's very well known that aortic valve disease is not infrequently associated with mitral and or tricuspid disorders, and some patients may already have a prosthetic valve in the mitral position at the time of TAVR. As you see in this multi-center analysis of nearly 2,500 patients, 91 patients had a prosthetic mitral valve at the time of TAVR, and the prosthetic valves were implanted with a median 14 years before TAVR, and mostly were mechanical valves. And you see here at the Kaplan-Meier curve, the 5-year follow-up. At 5-year follow-up, the mortality was the same between those with or without a prosthetic mitral valve. But interestingly enough, the TAVR device embolization occurred in nearly 7% in patients with a prosthetic valve, and in all instances, the distance between the prosthetic mitral valve and the aortic annulus was less than 7 millimeters. Here I have an example from our own series. You see the distance between the annulus and the prosthetic mitral valve ring is enough to give us to complete this procedure without any complication. How about the impact of mitral stenosis on outcomes after TAVR? Here I have a very large data set of 4,500 patients with mitral stenosis who underwent TAVR, 500, and surgical aortic valve replacement, nearly 4,000. And if you look at the table on the right side of the panel, you see that the TAVR was associated with a little less mortality and less complications, and the authors concluded that in patients with concomitant mitral stenosis, TAVR was safe and attractive option for patients undergoing aortic valve replacement with less complications compared with surgical aortic valve replacement. Here I have a single center experience from University of Bern from Switzerland. Again, nearly 1,000 TAVR patients, 1/5 with mitral stenosis, mainly degenerative mitral stenosis, and they found a 3-fold increased risk of adverse events at 1 year. And the risk was associated with the severity of the mitral stenosis and the presence of the rheumatic etiology. Finally, I have the STS registry data, over 30,000 TAVR patients. 11% were with mitral stenosis, and 2.7% was severe mitral stenosis. And the primary endpoint, including death, stroke, heart failure hospitalizations, mitral valve intervention at 1 year, was really significantly worse at 1 year in patients with only severe mitral stenosis, and there was no difference in terms of stroke between these groups. Now I have an example of a patient, really a very, very high-risk patient with chronic liver disease, multiple cancers, and gastrectomy, mitral stenosis plus aortic stenosis, 3-vessel disease, and decompensated progressive heart failure, recurrent attacks of acute pulmonary edema, etc. And we decided to proceed first with balloon mitral valvuloplasty, and then at the same session we performed triple vessel in the PCI, and then in a separate session we implanted the aortic valve successfully. 1 year after the TAVR, he developed again mitral stenosis, and we did redilatation of the mitral valve successfully to the patient. Well, bivalvular transcatheter treatment of high surgical risk patients with coexisting severe aortic stenosis and significant mitral regurgitation were shown to be feasible in this earlier publication. Here you see the procedure was MitraClip and TAVR, and even in the same session it was shown to be possible, and improvement in mitral regurgitation and TAVR. Last year a systematic review was published with 60 patients from 37 publications in high-risk patients concomitant with concomitant mitral regurgitation and aortic valve disease. As you see here, different types, different combinations of interventions were performed with a reasonable mortality. Well, I would like to share with you a case that I've done just the day before. This was a 87-year-old gentleman with severe mitral regurgitation and aortic regurgitation and stenosis, and his symptoms were escalated just over the last months, most probably because of the rupture of the chorda of the posterior mitral leaflet. First, we decided to perform all the procedures at the same session. We started with one clip, and then we implanted the second one. As you see, before the procedure, there was a significant aortic and mitral regurgitation, and this is the three-dimensional echo showing how the chorda is coming up at the P1 position. And here you see after first and then after second clip, the mitral regurgitation was really less and less significant. And then we proceed to TAVR, but this was a very tricky one. Slight calcification, severe aortic and dilated aortic root. So a couple of times the valve really popped out. And finally we managed to implant a little bit deeper, and then because of the severe or significant aortic stenosis, regurgitation, we implanted another valve. At the end it was reasonably acceptable aortic regurgitation. How about the tricuspid valvular disorder? Well, regretfully, we don't have robust data in those with tricuspid regurgitation. Here I have this publication from 2015, 500 TAVR cases at baseline, 15% tricuspid regurgitation, and as you see here, 2-year all-cause mortality and cardiac mortality was very high in those with tricuspid regurgitation. But interestingly enough, tricuspid regurgitation was not an independent predictor of 2-year mortality in multivariate analysis, and this was in contrary shown that the tricuspid regurgitation was interacted with the ejection fraction, and tricuspid regurgitation was associated with a worse prognosis in patients with an ejection fraction over 40%, but not the ejection fraction with an ejection fraction less than 40%. This is a systematic review and a meta-analysis showing us that the presence of tricuspid regurgitation, the presence of right ventricular dysfunction, and right ventricular size all were associated with a worse prognosis, an increased mortality in patients who underwent TAVR. And these parameters, echocardiographic parameters, were also analyzed in this particular meta-analysis and showed that right ventricular index of myocardial performance was associated with the worst prognosis. Well, Mr. Chairman, ladies and gentlemen, my take-homes include first, both mitral and tricuspid valve disorders are frequent in the TAVR population and associated with worst outcomes. And TAVR is feasible in the presence of native mitral and tricuspid disease as well as prosthetic valves. And dual valvular interventions are also doable in experienced hands and probably is the feature of the valvular therapies. I thank you for your attention.
Thank you, Dr. Otto, for your excellent presentation and the data. Dr. Spagnas, what's your experience in this complicated category of patients?
I think you're spot on. This is the most difficult group of patients to deal with. Multi-valve disease in any form of it, tricuspid, aortic, mitral. The only rule I follow is that aortic disease is above all and it comes first. Hemodynamically, I think, that's why. So if you have severe aortic stenosis, then I think the order of the treatment should be the aortic stenosis first, or aortic regurgitation, either of the two. And I agree with all the data you saw, Professor Otto, about the mitral stenosis. When it's moderate, I don't think it creates any problem. We can complete our TAVI without problems. Even when it's severe, we had recently a few cases that we managed to complete TAVR procedure without problems and defer the mitral stenosis for later on. Tricuspid, I think you should wait first some time to see if the tricuspid regurgitation was secondary to aortic stenosis, and if you see an improvement, that's fine. We know how labile tricuspid regurgitation is, so you should assess it very carefully after optimization of medical treatment. And what else is left? And mitral regurgitation, I think mitral regurgitation, the combination with aortic stenosis is the best studied of all. We've seen many publications, and we know the details about the difference between degenerative and functional MR. When you have degenerative MR, you don't expect to see a lot of improvement, and your chances are better when you have FMR to see an improvement after TAVR. And then, if you don't see the improvement, you can proceed with MitraClip at a later stage.
If it's possible for me to just say now quickly, it was a wonderful talk. I think in respect for time, we kind of have two conflicting things going on now. We have both a quick lunchbox and snack waiting for everybody upstairs. And we also have a very interesting live-in-a-box case that's going to be presented by Dr. Chalapas, which includes a Sentinel device. So it's kind of now a free-for-all time that we can go upstairs, grab a snack, and also see this TAVR case for whoever would like.